Good morning. I'm Steve Rissman, the program chair for the Workers' Compensation Educational Conference, and today we're going to talk a little bit about the convention generally and then very specifically about one of our headliner programs. The Workers' Compensation Educational Conference is scheduled from August 19th through 22nd at the Orlando World Marriott Center. It's the largest gathering of workers' compensation professionals in the country, drawing some 8,000 or 9,000 attendees. The program is extremely substantive. It's about 150 pages long, and any group that has any interest in workers' compensation will have program or multiple programs that they can attend. Really, there's something for everyone who's involved in workers' compensation. If you're involved in workers' compensation, you should be there. It's also turned into the best networking workers' compensation program in the country. Let me go over a couple of the highlights for this year's program. The sports keynote speaker is Lee Corso, the legendary coach and host of ESPN's Game Day. The entertainment is the party band, the B-52s. One of the best attended and audience favorite parts of the convention takes place on Tuesday morning. It's the live surgery presentation. This year we have Dr. Joseph Funk from Orlando Orthopaedic performing foot surgery. Welcome, Dr. Funk. Dr. Funk, tell us a little bit about your professional career, how you happen to be here.
I started my postgraduate out in Iowa for 4 years, and then I came here to do my residency. And during my residency, got to know the guys and gals here at the group, and they offered me a position. I've been here about 20 years now.
Wow, 20 years.
Yeah.
I've been 46 years in my firm, and I'm beginning to feel every year of it. Tell us about the type of surgery that you've chosen to show us.
We're going to do what's called a Weil, named after a Dr. Weil. It is a procedure that takes a weight-bearing metatarsal head, so we bear weight on the balls of our feet, and sometimes one or more of the metatarsal heads bear a little more weight than an adjacent bone. And we could talk about how that happens, whether it be a fracture lifts this one up and this one's down. But what the procedure does to a small incision is takes that bone and resets it into a parabola, or a weight-bearing distribution, equally across 5 as opposed to weight-bearing on only 4 or 3 or 2.
Let me interrupt for just a second. How does that accident happen in a workers' compensation format, and what are the symptoms that the injured worker has?
2 different ways. One, it could be a insidious onset or an overuse condition, whereas maybe they're in a position, they're wearing a little leather shoe or they're barefoot, maybe they're a dancer or performer, and that repetitive pressure results in pressure occurring underneath. Number 2, deep bruising. The toe starts to deform because of that deep bruising. So that would be a repetitive cause. Another cause, and that's rare, but it's possible. The other cause is smashing injury, jamming injury, where a metatarsal bone literally is elevated through the healing process, and then the adjacent bone simply bears more weight. So what we do is we surgically bring that bone down so that it equally distributes weight.
How do you bring the bone down? What's the surgery?
This is the procedure called a Weil. So let's assume that this bone is bearing too much weight for whatever reason. This one has elevated from fracture, or this one's depressed from overuse, whatever. Through a small incision, we access the joint, relax the joint through some soft tissue balancing or release. And then when we cut the second metatarsal, we cut it in a way that takes this metatarsal bone that's bearing too much weight, and we bring it back in line with the adjacents so that it's equal weight bearing as opposed to excessive weight bearing. Throw one small little 2.0 cortical screw, stays in place, goes on to heal, redistributes weight bearing, and works in the high 90th percentile, taking pressure off that spot.
That was really my next question. What's the recovery period for surgery like this?
Outpatient IV sedation, in the morning, out in the morning. Procedure is about a 20-minute procedure, actually, of my time at least, or maybe a few minutes more. After surgery, no return to work for a week or 2. On return, light duty, so it'd be more of a desk job only, wearing a little either fracture shoe or fracture boot. No heavy lifting, no heavy labor. Somewhere around the 4 to 5 week mark, if the x-ray looks good, the patient will start to transition back to a good tennis shoe or something big and wide. And if they're a pure office base where they're maybe on their tushy more often, they're pretty much back to regular duty week 4, 5, 6, somewhere in there. Heavy laborers, lifters, pusher-pullers, climbers, it's going to be every bit of 8 weeks before they get back. Or even someone like a school teacher or a nurse that's on their feet 24/7.
On their feet all day, yeah.
Mm-hmm.
I'm glad you differentiated between different workers. That's something that often gets us in trouble in workers' compensation. We're looking for a return to work period, and it's not a generic return to work. It depends on what their work is, whether they can return to work.
Absolutely.
But completely off work, only only a week or two, and then it matters what their job is as to how long the light duty is.
Correct.
Okay. And is there a generalized MMI period? I mean, after how long should they be as good as they're going to get?
Well, bone and tissue remodel into multiple months, meaning 6, 9, 12 months. However, it doesn't mean they're going to have symptoms that long. You're probably looking at best case scenario around month 3, maximum medical improvement. And this procedure, because it does not affect mobility to the area, it's a 0% every time.
Oh, even after surgery, it's a 0%.
Yes, it is.
That's almost like they're cured after the...
Right. Well, the 96 guide doesn't always take into consideration the severity of the condition or even the limitations after the surgery. So a major, rear foot reconstruction may lose a little subtalar joint motion or a little ankle motion, translates into a 2%, but yet they can't do heavy labor ever. And vice versa. They may have a little bit of limited subtalar joint motion, but go back to, chopping trees and
Well, I
pushing,
guess that brings us to the real threshold workers' compensation question. If they end up with a 0% impairment, do they end up with any work restrictions?
No. But again, on this procedure specifically, it would be
Yes.
0% and ultimately no restrictions. They'll be better than they were before they started. But again, if we talk about a major reconstruction in the rear foot, they may have a 4% whole person impairment.
Okay. And very serious restrictions.
Absolutely. Or they may have a 2% and very serious restrictions.
Depending on the occupation, depending on the person, depending on the nature of the injury.
Absolutely.
Okay. This is really the only convention where adjusters, nurse case managers, lawyers, and people who are not in the medical profession can see surgery performed. Do you see a benefit to showing us folks what goes on behind the curtain, and if so, what's the benefit of it?
I think you have some folks out there that have seen surgery, been a part of surgery, been in the theater, and understands what certain procedures entail, but by far the majority do not. So you either got someone who thinks, oh, that's nothing, the incision was only this big. Well, 2 of these incisions may reconstruct a shoulder or a knee, or you have others that think any surgery is the catastrophic end and they're never going to get better. So to correlate where an adjuster may see the code, ICD or CPT or whatever code they're looking at, to see what that looks like in the theater, I think is paramount. Gives them an idea, oh, that's the real deal, or hey, maybe that isn't brain surgery, they should be getting back pretty quick. So I think it draws a real nice picture for them and puts the whole picture together.
It sort of personalizes it, so they're looking at the injured person rather than just at sort of the textbook.
Absolutely.
Okay. And the next question is the opposite of that. There are a lot of doctors who attend the Workers' Compensation Convention. Not many of them are doing the live surgery presentation, but there are a lot of doctors that attend. Do you think it's beneficial for the medical profession to attend the convention? And if so, what are they getting out of it?
Right. Well, they're not going to get anything out of me because this is what they do, watching me. But to actually meet the adjusters, to meet the support staff. See, all we do is talk on the phone. We get a phone call. Why aren't they back at work? Or can we get them back to work? Or why did you do this or say this? Or we need something documented. To put a face with that phone call on both sides, I think is very, very important because it's people that we're dealing with. And to kind of take the legalese, no pun intended, or take the business out of it, make it a little more personal, understanding there's an injured person, good or bad, right or wrong, to be able to communicate and have a face and a relationship, I think is very important.
Yeah, I think it has gotten way more complicated in the last 10 years with things like major contributing cause and apportionment and things like that. So we as the lay people, the adjusters and the lawyers, and you as the doctors, sometimes aren't communicating about what's really important in the case because we're concerned with the legal questions. So I'm glad you brought that up. And having said that, thank you for all the information and thank you for talking to me today. Don't forget the date of the convention is August 19th through August 22nd. For more information about the convention and our social media platforms, see our website at WCI360.com. That's all for today. I'll see you in August.